let's go and talk a little bit further down and talk about the diseases of the anterior pituitary. Now this is the, as I said, this takes up about 80% of the pituitary itself. And let's talk about this case. A 32-year-old woman comes to your office because of milk-like discharge for over 4 weeks. Her examination reveals galactorrhea, but it's otherwise normal. And otherwise normal, I mean she doesn't have any visual disturbances. She doesn't have you do an evaluation of the visual fields, and she has no bitemporal hemianopsia, right? So she doesn't have visual field cuts. So what is the next most appropriate tests in these patients? So they want a couple of the tests that you're going to do in this patient, and we're going to come back to this case. Just let me talk to you a little bit about galactorrhea first. So that's what this patient have, or the milk-like discharge was galactorrhea, and she has hyperprolactinemia. So hyperprolactinemia is an excess in prolactin. It presents in women with the syndrome of amenorrheal galactorrhea. So that's the typical, the amenorrheal galactorrhea syndrome is the one that is associated with hyperprolactinemia. In men, it mostly presents with hypogonadism. It is very rare in men to cause gynecomastia or galactorrhea. It usually causes hypogonadism. And in men, because it's usually a macroadenoma, in women it's usually a microadenoma, probably because we pick it up earlier, but in men it's usually a macroadenoma. It also more commonly presents with visual field cuts, bitemporal hemianopsia. So bitemporal hemianopsia is very uncommon in women, probably because they present earlier. Men, when they have this, the hyperprolactinemia, and they have the prolactinomas, they usually have bitemporal hemianopsia. Out of all the pituitary adenomas, the most common, this is the most common functional adenoma that we see. But there's other causes of hyperprolactinemia, right? Like stress and stimulation. So it's not only a prolactinoma that causes this, even though the prolactinoma is the most common functional adenoma. There's other things like stress, stimulation, drugs, especially dopamine inhibitors. Remember that prolactin is under constant inhibition from dopamine, and once you give a patient a dopamine blocker, right, if you block the dopamine, this patient develops prolactinemia and hyperprolactinemia and galactorrhea. So please remember that. So one of the first things we do in these patients when we go back to the patient that we just talked about, one of the things you got to do is get a good medical history from her, make sure she's not taking any of these medications. Now reserpine is an antihypertensive medication. We don't use it anymore, but that was one of the reasons it used to cause galactorrhea. And H2 blockers like cimetidine and stuff like that, they sometimes cause galactorrhea. And so forth. And then the third one that I want you to remember is hypothyroidism. Now, this is the issue. Usually prolactin is only under constant inhibition from dopamine. There is no enhancing factor under normal conditions. What happens in hypothyroidism, though, if you have primary hypothyroidism, remember your TSH goes up, right, from the pituitary, that does nothing, but your hypothalamic hormone also goes up, and this is called thyroid releasing hormone, or TRH, thyroid releasing hormone. And thyroid releasing hormone under normal conditions probably does nothing to prolactin, but if thyroid releasing hormone is very elevated, very increased at very high levels, then what usually happens is that it enhances prolactin, and you get hyperprolactinemia and galactorrhea. So one of the things we always rule out with galactorrhea is hypothyroidism. Very important that we check. The most easy way to do that is check a TSH and make sure it's normal. And then the fourth one, I didn't put down here, but I want you to remember, it's in your notes, it's very important, is pregnancy. Now, usually galactorrhea occurs after pregnancy. We all know that. It's not usually during pregnancy that we see that. But some patients, even in the second trimester, they develop a little bit of galactorrhea. So please remember, make sure you get a pregnancy test. So thyroid test to exclude primary hypothyroidism, get a good drug history to make sure the patient's not taking any medication that would block the dopamine secretion, and number 3, get a pregnancy test. That's the most important thing. If you exclude that, if you exclude all these basic categories, then you could check along with that a prolactin level to make sure that this is the prolactin levels are high, and if the prolactin levels are high, then it's likely to be a prolactinoma, the most common functioning adenoma in the pituitary. And then after that, what you do is you image the pituitary with an MRI to localize the adenoma in the pituitary, the prolactinoma. So the workup is to exclude drugs and hypothyroidism, exclude pregnancy. Then after this, we check prolactin levels, right? So now if we excluded everything else and we have high prolactin levels, it's a prolactinoma, right? And then we go to an MRI to localize it, to see how big it is, to get an idea of what is it, if it's causing any pressure phenomena and stuff like that. Treatment, always you start off with medical treatment. If the patient is missing dopamine, what do you give them? You give them a dopamine enhancer or a dopamine agonist. The 2 drugs of choice are bromocriptine and cabergoline. Now, bromocriptine is the one that's been studied the most. It's been studied for decades now. It has a worse side effect profile. It probably has been studied more. We know long-term what it does, but it has more side effects, nausea, vomiting, and stuff like that. And that's why some people prefer to use cabergoline instead. Now, cabergoline, though, has never been tried in people that are pregnant. We don't know what the outcomes are. We don't have enough data, so you have to be very careful in those patients that are pregnant or that are about to get pregnancy. Remember, one of the reasons to reverse galactorrhea, amenorrhea in young patients is for them to be able to get pregnant. So we start off with both of these drugs. Both of these drugs are dopamine agonists. Both of these drugs work very well. They suppress prolactin levels. And what's very important for you for the boards is that they also reduce the tumor size. So not only do they reduce prolactin levels, but they reduce tumor sizes. So that's why these drugs, we start from the beginning with medical treatment, pharmacologic treatment in patients with prolactinomas. If this doesn't work, especially if the patient's having a lot of pressure phenomena, I mean visual disturbances, visual field cuts and stuff like that, then you have 2 options. Surgery and radiotherapy, but these 2 come later because both of these scenarios, both surgery and radiation, XRT, they have about 30% of panhypopituitarism. They cause, in 1/3 of the cases, panhypopituitarism. So you don't want to start off with these treatments unless you show that the dopamine agonists don't work or the patient's getting worse on the dopamine agonist. So remember that. Now, they ask us a question: which are the patients that are, we have to be aggressive about treating with prolactinomas, and that's the patients that are in childbearing age, because if you don't reverse that quickly, then it can't get pregnant. Older patients, older women that have small prolactinomas, well, sometimes, we could, be slow, very slow in the treatment and watch and wait and stuff like that. But the young patients, we have to be aggressive about. They may also ask us a question, the young women we have to be aggressive about. We also have to be aware of this, that I said it before, women generally have microadenomas, where men usually develop macroadenomas, and it's the men that usually develop the symptoms from the head, the nausea, the vomiting, the blurry vision, the visual field cuts. If they occur, they're going to usually occur in men. And they may ask a question, well, which are the patients that will eventually need a more aggressive form of treatment, surgery or XRT? And the answer is it's usually the men, because usually the men have the macroadenomas. So we exclude simple stuff in galactorrhea. After that, when we exclude pregnancy, drugs, and hypothyroidism, check prolactin levels. Once the prolactin levels are elevated, you've diagnosed the prolactinoma. This is the most common functioning adenoma of the pituitary. Get an MRI to visualize it. Start the treatment, usually with dopamine agonists. So let's go back to this case. A 32-year-old woman comes to your office because of milk-like discharge for over 4 weeks. Her examination reveals galactorrhea, but it otherwise is normal. What are the next most appropriate tests? We check a TSH, we get a good medication drug history, and we get a pregnancy test, and then we look at the prolactin level if all these are normal. Most people get all these at the same time, but they want you to exclude these things first. Now, the second disease of the anterior pituitary, where we have hyperfunctioning of an organ, hyperfunctioning of a hormone, I should say, is acromegaly. Now, in acromegaly, we have excessive growth hormone. So, you know, these patients, if they develop acromegaly, or they have the excessive growth